Welcome to the Virginia Hospital and Healthcare Association's Patients Come First podcast. We are pleased to be joined today by Dr. Allison Jackson, who is the CEO of Integration Solutions Incorporated. She's also a licensed clinical social worker. And in a bit of a change of pace for the podcast, we're actually going to focus on a particular topic that Dr. Jackson is a specialist on, and that's exploring trauma-informed care in healthcare settings. Dr. Jackson is participating with VHHA's Virginia Hospital Research and Education Foundation, which is the organization with the association that runs all of the educational programs. And right now, VHREF is conducting an ongoing learning series about adverse childhood experiences, which is sometimes referred to as ACEs. And so Dr. Jackson is going to share some perspective on that with us as a bridge between programs that are ongoing in this learning series. So welcome, Dr. Jackson, and thanks for being with us.
Thanks so much for having me. So I think I'll start just doing a little bit of framing of ACEs and resilience. The two are highly connected. As was mentioned, there's a field of study now started by the Center of Disease Control called ACEs, and that stands for Adverse Childhood Experiences. And really this was a large epidemiology, oops if I said that correctly, but done on epidemiology of understanding how kids have positive and negative experiences in life, and how some of those experiences, when they're intense, prolonged, repeated, and particularly unaddressed, can have some serious effects on later health outcomes. And so those were named as adverse childhood experiences. And so to get some frame of this on stress, is there are certainly positive types of stress in health, like even taking a tough test or having a playoff game. Actually, some things help us remember better and helps the brain remember better. There then is tolerable stress, and that's when you have something like a death of a family member, and it's activated, it's time limited, and you have a whole lot of buffering by caring adults. And so we stay in a higher level of stress, but then we come back down. What we're going to talk about today is known as toxic stress or complex stress, which is really where ACEs falls into. And these are things that when we have different types of abuses, emotional, physical, sexual, different types of neglect, emotional neglect or physical neglect, or other types of what they call household dysfunctions like divorce or separation of a caregiver, domestic violence in the home, someone in the home with a substance abuse issue or diagnosis, a mental health issue or diagnosis, or someone in the home that goes to prison or is in jail. And what's been shown in the ACEs study is that when kids have these types of experiences, there's a dose relationship. The more of those 10 things that I just named that occur, actually the more negative health outcomes we see when we look at health population attribution or population health. So for example, folks that score a 4 out of those 10 events are over 550% more likely to become an alcoholic, or over 1,100% more likely to use IV drugs, thus highly connected to our current opioid crisis. At a 6, there's evidence that someone's more likely to die at an average age of 60 versus 80, a 20-year difference. And so while that may not apply to every individual, and certainly doesn't, that has these events, depending on the buffering and resilience they had, it becomes a really important foundation of health, and it's actually been named by the Center of Disease Control as the prime determinant of health. And we estimate that about 223 million adults will be affected by trauma in their lifetime. And we think that about 46 million out of 76 million children this year will actually witness some type of violence. So it's not just some kids in that neighborhood or some adults affected by this. It's actually about 2/3 of the population. And about 1 out of 6 have those scores rising above 4 or more. And so understanding ACEs then, the question becomes, what can we do about that as health professionals? And I think the frame and where the questions are going to go today are around what SAMHSA, the Substance Abuse Mental Health Administration, terms the 4 R's. One, the first R is realize. We need to realize the impact of ACEs and toxic stress to those we serve and how it affects our communities. Second, we need to recognize. We need to know when someone we're serving may have experienced some of those those ACEs. And then the next R is respond. We need to know how to respond effectively and offer them the best, most evidence treatment. And the fourth R then is we need to resist re-traumatizing. So we need to create our systems, our healthcare systems, as best as possible, not to add trauma to folks who may have already experienced it as a child. And so the real function, and I encourage folks to go to the Center of Disease Control website. It's interesting that ACEs, Adverse Childhood Experiences, is the most trafficked website of the CDC and currently the least funded program. But if you look there, they have a pyramid of health, and you'll see ACEs is at the bottom. And so what we want to think about is resilience and protective factors at each level of ACEs. And the science around this is now being coined, coming from Washington State Neuroscience, and they've kind of combined 4 areas of science. They've combined neuroscience, epigenetics, adverse childhood experiences, and the science of resilience. They're really using BRFIS scores, so the behavioral risk surveillance system factors that all states use for BRFIS, to look at what help actually helps. And they've kind of put that in 4 categories. So I'll briefly describe those because that'll be some of the questions we kind of explore today. One is that we know that people having social emotional competence is really important to their health. And that's basically being able to have emotional intelligence, being able to verbalize their feelings and communicate those feelings, and actually being able to regulate their emotions. Also hope, and that's not a feeling, that's actually a sense of future self. So being able to envision yourself as healthy and what you would want to be actually has a strong influence on changing health behaviors. The second is help. People who have at least 2 concrete supports in their life tend to have better health outcomes. And those aren't Facebook friends. These are concrete supports. The person I call when my child's been screaming for hours and I'm worried I might make a poor choice, and they come over and help me, or helps me get to work one day. The third is what's called community reciprocity. And this is really the best way to think of it as like an old 60s movie where Mrs. Jones is sitting on the front porch and there's a young person kind of walking towards some kids smoking. And she says, "Hey, Johnny, I know your mom, I know your dad. Don't you walk over there, come over here." It is this primary network of protection in your community, people that see you every day that look out for your health. And how can we strengthen that? And then social bridging, which directly links to us, is the ability for someone to raise their hand for themselves or an immediate person in their circle of friends and ask for professional help. Say, I think something's going on and I'm trusting a system to come in and help that person. And so what these have shown in about 25 states now actually measure ACEs in their BRFIS data they get for their state. And excitingly, Virginia began doing that in 2016. And that data is just dropping this past month in July of 2017. Be our first look at ACEs in Virginia. And now states have moved to measuring resilience. And these are the factors that are coming up as really changing health outcomes. So that's kind of a brief overview of what ACEs is in healthcare, and what our focus today will be: how do we really improve resilience in our healthcare systems for the next generation?
Well, thank you for that very comprehensive overview. I know that, as we mentioned, the VHREF is conducting this ongoing learning series, which you have been leading as sort of the keynote speaker. The first session was actually in June of this summer, and there's another one upcoming. And I know that part of what you are focusing on is really trying to work with members of the healthcare community, healthcare providers in hospital and other care settings, to adapt their practices and procedures to address the needs of children and caregivers who enter the healthcare system who may have had one of these traumatic experiences. So if you would, could you please just sort of take us through some of the ways or some of the strategies that you recommend being put in place to deal with and address the circumstances that these children and or families have encountered?
Absolutely. It's a great question. So in that series, several different hospital and healthcare systems have been joining us, bringing together decision makers in their hospitals, as well as direct care and frontline practitioners, to begin thinking about exactly what you just said. What can we do? And there are kind of three areas, I think. I think one of them is really thinking about how do we start screening for this? How do we start using universal precautions? When we look in public behavioral health care systems, we believe about 90% of that population has experienced a trauma. So while this crosses all socioeconomic demographics, we do know that certain areas can experience more adversity than others. And so we need to then think about these high levels of 2/3, so these 70 some percent to 90%. The fact is that incorporating resilience healthcare practices isn't going to hurt that other 25 to 10%. So we go into this idea of universal precautions. Whether I know you've had trauma or not, there's certain things that I'm going to do. And so we're really exploring those ideas of what can I do when you come into a waiting room? How can I set that up? How can I think about incorporating your family? How can I think about identifying your support systems? All of these things that kind of come from neuroscience. And then how can I do some education about this really important health issue? And then moving into some more specific areas of what is beyond screening, and then who am I then going to do an integrative healthcare approach with is if what comes up is some behavioral health needs, who is my behavioral health partner I have embedded or who I'm going to do warm handoffs with? What are other areas like substance abuse, or even we know there's a high correlation between trauma and asthma. How am I going to work with my other health partners to really have the same kind of common language and connect around this issue? And so that's really thinking about, I've got mom and maybe dad or another caregiver in front of me or another partner in front of me, and they have high ACEs, right? And so I've got to think about how do I moderate the effects that they're experiencing, but then I also want to educate them so I actually lower the ACEs of the next generation. Just briefly, some folks that have taken that on in Washington, who's the state that's done this work the longest, is Walla Walla, Washington, as well as others. And they really took on what's known as a Children's Resilience Initiative, and they really targeted parents as the number one protective factor for kids. And over a 10-year period, they were able to actually show a correlation between doing these types of resilience work across all systems in a community to reducing children hospital incidents and accidents, reducing substance abuse in the community, a lot of different domains, and actually lowering the average ACE score of people between 18 and 35, the one that had that 10-year exposure, from 6 to 3, which had amazing health outcomes for that generation. So that's the other part, is this next generation health. And then finally, what we have looked at is kind of what's known as super utilizers. So folks that really are taking up a large part of the healthcare dollars and have very complex health issues. We actually realize that the majority of them have high ACEs. So how can we serve that population better? So that's kind of a broad stroke. And I don't know if we want to go into like some specific examples with questions that would be helpful in those areas.
You referenced the Centers for Disease Control and Prevention website as a good resource for a lot of this material. I know there's another website as well that's a good repository of a lot of this information, which is healthcaretoolbox.org. And I know that on that website there's a wealth of resources, as well as some of the basics of trauma-informed care. For example, this sort of approach that is the initials D, E, and F, which is reducing distress, emotional support, and remembering the family. Would you mind taking people through sort of that approach and how that fits into this broader framework?
Absolutely. And so the website you just mentioned, the www.healthcaretoolbox.com, comes from the Children's Hospital of Philadelphia, and it was really a lot of research was put together. And so when we think about in healthcare, when we were really pushing the ABCs, air, breath, and cardiac, and how we really everyone is taught to think about that, to support the health of others, and also when there's a crisis to support. So also healthcare folks are now adapting the DEF. And so the idea here is to start teaching everyone in healthcare to think about the DEF, so that when I am treating someone or someone comes in my office, let me think about the distress they may be going on. What are their fears right now? What are their worries? What are they afraid might happen? What do they think it may occur in this particular office? And they ask questions about that. Can we normalize that distress? And then in terms of E, emotional support, what does that patient need right now? Who do they need right now to be with them during the intervention? And how do we figure out how to incorporate those folks? If we're thinking about, for example, a surgical intervention, and we know that we have the opportunity to have pre-surgery meetings, can we have those conversations about what the fears are and come up with some solutions about how to lower that distress, and think about who can come that day, who will be their supports, what do they need with them? That would be an example. Or even when they're in an emergency room situation, is there a waiting room that has some tools that could lower their distress? Do we have some people that could even be assigned to kind of watch out for kids and know general ways of, for example, blowing bubbles? Very interestingly, breath is one of the top ways to lower distress. And there's a particular 1-4 breath. And so blowing bubbles actually simulates that breath. So some folks are redoing their waiting rooms and thinking about, how can I have puzzles? How can I have bubbles? How can I have coloring? The bilateral motion of coloring reduces that. So how can I think about ways to reduce distress? And then how can I think about, even beforehand, what that person needs for emotional support? And then the last, which was the F, is critical. Just as I said, parents and caregivers are the number one protective factor. We always need to remember family, and that's the F. And we really need to kind of do some screening of what are some current family stressors and what does the family need right now to be successful in supporting the health of this child. I think I saw something recently that we know 10% of the health treatment really and success comes from what happens in the clinic, meaning 90% is what happens once they leave, right? And so that's a lot about the family. And so if I'm thinking about how to set the family up for success and continuing health gains, then that's really important. And so I would just say, really starting to focus and get that kind of branded in your healthcare agencies, or am I asking the DEF questions, and thinking about that, including it in my intake forms, training my staff about that.
Based on some of the statistics you cited about the incidence of adverse childhood experiences, it sounds like not only a very important topic, but one that is in need of the kind of attention that you and others are bringing to it. And that's why we are so pleased to have you participating in the Virginia Hospital Research and Education Foundation ongoing Adverse Childhood Experiences learning sessions. So thank you for participating in the Patients Come First podcast today. Again, for folks who would like more information, that website is www.healthcaretoolbox.org. Also, for folks who want more information about VHREF programs, they can visit them through the VHHA.com website or keep up with VHREF on Twitter. Their account is @VirginiaHREF. And Dr. Jackson,
Julian,
yes,
if
ma'am.
I could add one more piece there, because you're giving some great resources as we wrap up. And I just wanted to say, one of the things that we know is that a lot of folks, as they take this on organizationally, want some more support. And our organization, Integration Solution, is just one example of that. But as was mentioned before, we can be reached at integrationsolutions.org. And one of our focuses is really walking organizations through how do we lead this change of transformation. And so we offer education and support in that area, technical assistance, and leadership development. So, which is why we're so excited to work with VHHA and VHREF in this expedition of really looking at this issue.
Well, thank you very much again for joining us and for all your work on this important subject.
Thank you so much.
That's going to do it for today's episode of the Patients Come First podcast. You can find new episodes as they become available at www.vhha.com. You can also find episodes of the podcast on SoundCloud and on other popular podcast portals. We also encourage you to engage with us on social media, including Facebook and Twitter. If you'd like to send us comments, questions, or feedback for the podcast, you can do that through our Twitter account at VHHA using the hashtag PatientsComeFirst. Thanks.